code on this computer. Okay, all right. So now we are back on track. Okay, so tell me, Nikhil, Rane, what do you understand by level of evidence? Hello, can you hear me? Hello? What's happening here? Guys, can you hear me or not?
Yes, sir.
Yes, sir. We can hear you well, sir.
Yes, sir. Yes, sir.
So why is Nikhil not responding here? Come on, respond to me.
Yes,
because
sir.
I'm stressed with 3 screens and I'm trying to do things for you, okay? So respond back to me. All right.
Yes, sir.
So Nikhil, what do you understand by level of evidence? Give me what is the meaning of level of evidence? Or if you don't know, say I don't know, but respond to me, please. I can't see you.
Sir, it's categorized as category 1, category 2A, 2B, and 3.
Level of evidence. Level of evidence.
Sir, it is a recommendation based on observation made.
No, but tell me the level of evidence. No? Because what are the level of 1 to 5? What is level of evidence 1 to 5? Simple.
Level
Okay.
1 is...
Okay,
level,
stop, Nikhil. Just wait. Just wait, okay? Simran, come in. Can you tell me 1 to 5 level of evidence?
Yes, sir. So, level of evidence is whether the treatment is recommended for the patient or not recommended for this patient. So, there are 5 levels of evidence.
No, that is stages of recommendation. I'm talking about level of evidence.
Right, sir.
There are 2 separate questions. One is level of evidence, and second is stages of recommendation.
Stages of recommendation.
Tell me level of evidence.
So level of evidence is the evidence is from at least one large randomized trial of good methodology.
That's one.
That means there's low chance of bias and or meta-analysis and well conducted randomized trials.
Okay. Level of evidence too.
Level of evidence is small randomized control trials, so large trials with bias, and meta-analysis of trials, but with a little bit of discrepancy.
Okay. Level of evidence 3.
Level of evidence 3 is prospective cohort studies. Evidence 4 is retrospective cohort studies or case control studies. And level 5 is sir, expert opinion or just case report, sir.
Excellent. That is excellent answer. This question will be asked many times in the exam, either as an MCQ or a Viva. You must know these 5 level of evidence, okay? So please make sure that you know this level of evidence. It's quite important, yeah? Okay, so this is it. Every time it will come somewhere or the other, this question will feature in the exam, okay? And you need to know the level of evidence, quite important, all right? Okay, my next question is Biswaroop with us?
Yes, sir.
Okay, Biswaroop, what is the grades of recommendation?
There are classes of recommendation. Classes of recommendation are class of recommendation 1, A, class of recommendation 2, A, B, and class of recommendation 3. This is as per the SCC-AHA guidelines that they follow. There is also the Scottish Intercollegiate Network where they give the classes of recommendation as A, B, C, and D.
Okay, good. So what is A, what is B, what is C, and what is D?
So class of recommendation A is basically where there is a meta-analysis of RCT with very high quality data to prove that the treatment is definitely beneficial and benefit is more than the risk. So 2A is what is the class of recommendation. It has a registry study, randomized control trial with the absence of a meta-analysis, high quality data to show that the benefit is definitely more than the risk. 2B tells us that there is a no randomized control trial or the BNR, and there is high quality data to show that the benefit may be more than the risk. So it may be a feasible option. And class of recommendation 3 is there is no benefit. So the treatment is harmful than the.
Okay. If I ask you grades of recommendation for A, B, C, D, and E, would you be able to tell me that?
The Scottish Intercollegiate grade is meta-analysis of RCT applicable to the target population and shows a consistency. B is there is a body of evidence which includes studies with an overall consistency and whose results can be extrapolated to the population. Class of recommendation C is there is a body of evidence with 2+ studies and which are basically good case control and cohort studies where the relationship is mostly causal and shows an overall consistency which can be extrapolated to the target population. Class of recommendation D is it is a level 3 or level 4 level of evidence where there is non-analytical studies or case series or expert opinion and might be extrapolated to the population.
Okay, that is the Scottish Intercollegiate. There is one more grade of recommendation which goes A, B, C, D, and E. You're absolutely right. SIGN is what you need to know. Okay, everybody should know. If you're going for FRCS examination, you should know SIGN. Okay, the Scottish Intercollegiate is very important. That is the one that we use for all our cases. But if you read literature, there is one more type of level of evidence where A, B, C, D, E is there. One is A is strong evidence for the treatment. B is moderate evidence for the treatment. C is insufficient evidence for efficacy. D is moderate evidence against efficacy. And E is strong evidence against efficacy. Okay, so you need to know both of these. One is the Scottish.
Is that the United States Public Health Guideline System which uses ABCD?
Right. Absolutely right. Absolutely right. So this is the next one which I was just about to show you. Is my slide come up or no? What is happening here today? I don't know. My computer is complete. So this is another way that you must know. Okay. So strong evidence for efficacy, moderate evidence for efficacy. C is insufficient evidence for efficacy. D is moderate evidence against efficacy. And E is strong evidence against efficacy. Okay. So also know the Scottish recommendation and also know this one. Okay. You must know both of these, how we study. Every recommendation, every paper uses one or the other, and the paper will always tell you which one they have used. So you must know whichever is the one that is used. ESMO guidelines has used this one for this level of recommendation, okay? So strong evidence for efficacy, moderate evidence for efficacy, insufficient evidence for efficacy, moderate evidence against efficacy, and strong evidence against efficacy. That's the easiest way that I can explain to you. Did it make sense to everybody or no?
Yes, sir. Yes, sir.
Yes, sir.
All right, now something is wrong with my computer. I'm struggling with the thing. Okay, what are the highest level of efficacies? Hang on, just one. Sorry, my computer is completely playing up. Okay, Nikhil, come back in. What are the investigations that you need for definitive treatment of lung cancer?
So investigation to diagnose and investigation to fitness.
Excellent. I like that answer. That is the way to answer. Okay. So just tell me investigations for diagnosis quickly.
Assess sputum examination, chest X-ray, CT,
Sputum nahi re, bloods re. Pehle bloods. First is bloods, not sputum. Lung cancer cannot be diagnosed on sputum examination. Okay. So sputum is not part of that thing. Okay. So now I understood all that. Now just tell me radiologically, how will you diagnose lung cancer?
Chest X-ray, AP and lateral view, CT chest with abdomen, PET scan, and MRI brain.
Okay, MRI brain. That is important. So always remember that you have to go in CT scan and PET scan. This is level 1A evidence. Okay. Now my question to you is again, 36-year-old guy comes in with a CT scan done about 6 weeks ago, with showing a lesion in the right upper lobe, a single station N2 node. What will you do for this patient?
So
he is needle diagnosed lung cancer, adenocarcinoma.
So I like to repeat a CT scan because it's a 6 weeks prior.
Okay, so what is the recommendation for the CT scan? How soon should you accept it? CT or PET?
Sir, 4 weeks.
Good, I like that. That was my question. I was very clearly asking you that all reports should be within 4 weeks, okay? In the exam, please remember this point. There is one MCQ I've seen actually in the thing where the CT scan was 8 weeks old, and they asked you, should you do the correct treatment is, and surgery was given as one of the answers, and a lot of people chose surgery, but one of the options was repeat CT scan. Okay, so please remember this one, this third point which I just made, that in the exam, if you are ever given a scenario where the CT is more than 4 weeks old, the answer is repeat CT scan. Does it make sense to everybody or no?
Yes, sir.
Okay, will you operate on this patient? Directly do a lobectomy?
Sir, no, sir. I like to have a EBUS to know the stage of mediastinum.
Excellent. The next important point is that you must stage the mediastinum. Okay, everybody, you must stage the mediastinum. Always in lung cancer, in the examination scenario, you must stage the mediastinum. Okay. The next important point, I'm sort of for this is all revision for the exam. So I'm only putting the highlights of the important points that you need to know. Okay. 1 minute, there are a lot of people trying to log in. It's becoming very difficult for them.
Yes.
Okay. So staging the mediastinum is absolutely any lung cancer case. The only exception, what is the only exception where you will not stage the mediastinum and operate directly? Nikhil.
Sir, a peripheral lesion less than 3 centimeter.
Yeah.
Without any radiological evidence of metastasis.
Excellent. That is the answer. I like that. Okay. Everybody is okay with this or no? Anybody's got any questions, please ask me. Okay. This is discussion. So I want you to sort of interact with me. Okay. Next question. Simran, will you go ahead and operate on this guy on the information in front of you?
No, sir. We like to discuss the patient in a multidisciplinary team meeting, sir.
Excellent. Thank you very much. Always MDT has to be mentioned in the exam. Again, I'm trying to highlight the important points that you have to talk in the exam. Okay. And any more investigations besides this that you see on the screen? Simran, any more investigations?
So we'll need a MRI brain.
Thank you. So you need an MRI brain. Well done. So again, the point is that every single one, I'm trying to tell you what you must answer in the exam. Okay. Very important. MRI brain. Don't forget MRI brain. Okay. All right. Now let's go to the next scenario. Okay. I'm really feeling shit because my computer is playing up, so I'm not able to control the situation. It's horrible. Okay. Simran. No, Simran. Give somebody else. Biswaru. Biswaru?
Sir.
So you have this guy, 36-year-old guy, whom you have done. You've done all the staging. You've done a CT scan. You've done the PET scan, and there was some evidence of slightly enlarged lymph nodes. EBUS was negative. Okay. So on table, you went ahead and did a VATS lobectomy. You started doing a VATS lobectomy. And when you started doing a VATS lobectomy, you found an enlarged lymph node at station 4. Are you still with me? The scenario is clear. You're already into theater. You're already into theater.
Female. Yes, sir.
You're already into theater. You started operating.
Yes, sir.
You found an enlarged, suspicious looking lymph node at station 4, which was not present pre-operatively, okay, in the assessment. So you send it for frozen section. Single lymph node you send for frozen section. What are you going to do? And the
Sir,
frozen
it was-
section came back as metastases in N2 at station 4.
Sir, I understand this patient was basically a stage 3 36-year-old male who had a lymph node positive. EBUS was done and EBUS was negative, and I have taken him up for surgery. So before taking him up for surgery, have I not done a TEMLA or a VEMLA on him?
It was all negative. It was just a small lymph node. EBUS was negative. You went ahead and operated, and you have seen a lymph node at station 2, which at station 4, and you send it for histopathology. Okay. And the frozen section came back suspicion of cancer in station 4. What will you do?
I'll minimum take 3 lymph node stations and send them for lymph node staging, the medicinal staging.
Station 4 has come back positive. 7 is negative. 2 is negative. You are the operating surgeon while doing a lobectomy. What are you going to do?
Even then, sir, it becomes isolated N2 disease in that case if station 4 is positive on the contralateral side, I believe. On the knee side. So if station 4 is positive, it's still a
ipsilateral.
Okay, yeah, you're getting it. So sir, even if station 4 is positive on the same side, 2 and 7 are negative, it is still an isolated N2 disease. So we have to, depending on the result of the frozen section, we still have to think that this is a potentially resectable tumor, and we have to continue with the surgery, operate him, and follow him up with a multidisciplinary team meeting regarding his post-operative adjuvant chemoradiotherapy.
Okay, so basically I asked you a straightforward question. The answer is very straightforward. The question I was asking you is, will you continue surgery or will you discontinue surgery?
No, since I have started, sir, I will operate him. I will operate the lesion. I will take it out. I will, if any other lymph nodes are found, I'll send them for medicinal sampling. And after his surgery, we will do a multidisciplinary team meeting and decide on his adjuvant chemoradiation.
Okay, so whenever you are asked this question, that intraoperative N2 disease, on frozen section you found incidental N2 disease, the answer is please complete the resection if the patient is fit for surgery. Okay? This is the answer. This is a scenario which very often happens to a lot of us. So if there is a single station N2, which you found intraoperatively, the answer is you complete the surgery, but you do a systematic mediastinal nodal dissection and then discuss in the multidisciplinary team meeting 6 weeks following the surgery, and then this patient should be considered for adjuvant chemotherapy. Okay? Level of evidence 1A. Is this clear?
Yes, sir.
So did you understand the scenario? Everybody who is listening, did you understand the scenario? If you are ever asked in the exam that on table you found N2 and you sent for frozen section, single station came back positive, the answer is complete the resection and follow it by adjuvant chemotherapy. Okay? And again, level of evidence 1A. Okay? So this is very clear-cut answer. Post-operative routine radiotherapy is not recommended. Okay? All right. Is it clear to everybody? Did you understand the first scenario? I'm giving you answers for your exam. There are a lot of people trying to log in here. It's becoming very difficult.
Sir, I'll be host, sir.
No, you need to focus on the question answers. So I want you to focus here. Okay. All right. Who else wants to take the next question? Quickly volunteer so that we don't waste time.
Yes, sir. Dhanesh, sir.
Dhanesh, this is your patient. Tumor in the right upper lobe, right lower lobe, and a single station N2. What are you going to do?
Single distance is
EBUS has shown that the N2 was positive.
so still I will do the surgery and followed by the adjuvant chemotherapy, sir.
Okay, good. So remember this, if it is a single station N2 and a patient is fit for surgery, you do offer him surgery. This is the only scenario in N2 when you offer surgery to the patient. Single station, fit for surgery. That's the answer I want to hear. And then you follow it up with adjuvant chemotherapy. That's one treatment. If the patient is, if it is discussed in the MDT, and if the oncologist feels that it's a voluminous single station N2, then you have the option of giving induction chemotherapy followed by surgery. Okay?
Okay.
And the third situation is you also have the option of giving induction chemoradiotherapy followed by surgery. So, any time in an exam, if you're asked this question, what do you do in a single station N2? The answer is, number one, if the patient is fit for surgery and it is a small single station N2, I would offer him surgery followed by adjuvant chemotherapy. No, the first answer is I would discuss in the MDT. The second answer is I would offer him surgery followed by chemotherapy. There is also an option of discussing induction chemotherapy followed by surgery or induction chemoradiotherapy followed by surgery. All three situations are okay. But this is, again, the only situation in N2 where you will offer surgery. Normally in N2, you do not offer surgery. Okay? So two situations where you may offer surgery. Number one is incidental N2 at the time of surgery. So intraoperatively, you found an N2 node, you will continue the surgery. That's number one. And number two, if it's a young, fit patient with a single station N2, there is now evidence to suggest that you could do surgery followed by chemotherapy. However, if the MDT feels that induction chemo or chemoradiotherapy should be given, then that's okay. It can be followed by surgery. So in the exam, don't take just one answer. Give all the possible six situations. Okay, this discussion is extremely important. These are real life clinical scenarios. Okay, did everybody understand this or not? I'm really stressing a lot on this because these are. Yeah, Soumya, please ask the question.
I have a doubt. Sorry if it's a silly doubt, but does the location of the tumor, like you specified it as right lower lobe, does it have any bearing on the decision, or it could be anywhere and we would still just focus on the single station N2?
Yeah, it's actually the size of the tumor that matters more than the location of the tumor. So again, if you go into further breakdowns, if it is an upper lobe tumor and you have got a station 7, then you are more likely to give induction chemotherapy.
Okay.
Do you understand? That's how we differentiate in a clinical. If it is station 7 and if it is a upper lobe and a station 4, then you are more likely to do surgery followed by chemotherapy. Do you understand? So if it's a lower lobe tumor and it's a station 4 single node, then you are more likely to give induction chemotherapy followed by surgery.
Okay, sir.
If it is a large size tumors like a size 10, a 10 centimeter, and station 7, you're more likely to give induction chemotherapy followed by surgery. I don't want to go into more details because it will confuse people, but this discussion happens in an MDT. Again, if the histopathology says poorly differentiated tumor and there is a single station N2 disease, you're more likely to do induction chemotherapy followed by surgery. If the FNAC says highly differentiated adenocarcinoma and a single station N2, then you are more likely to offer surgery first followed by adjuvant chemotherapy. Did you understand how the MDT thinks and makes a decision?
Yes.
So a number of factors come into play. One is size, one is location. Number 3 is differentiation.
Okay, sir.
If it's a central tumor and it's a station 7, then you will give induction chemotherapy followed by surgery. Yeah?
Okay,
Is,
sir.
is everybody more confused or less confused? Is it clear? I want these answers to be very clear.
Clearer, sir.
Yeah, because these are very, very critical points which come in the exam. So today's session is all very definitive answers. Okay. So please be clear about these things. Okay. Next, who wants to take next?
Sir, one doubt, sir. One small doubt.
Yeah, quickly, come in.
Sir, does a 3A into single station and single zonal have the same treatment options? Because single zonal might be more than one station. So do we operate if there are like station 2, station 4, single zone? Do
No,
we
don't go
operate
into
that test?
no, don't go into always the guidelines have looked at stations rather than zones. Okay, so don't go into the zonal discussion. It will confuse
Okay.
you more. Okay, that is for experts like us to discuss. In the exam, you will not be asked such complicated scenarios. You will be asked single station. Listen to the word carefully. It will be station, not zonal. Okay, zonal is a very big area, and zonal becomes multi-station. Okay, so the guidelines always talk of single station, not single zonal. Okay, so don't confuse yourself. Stick to single station and multi-station. That is the answer you must be able to give. There will be an MCQ on this. I promise you there will be an MCQ on this. Okay, and you have to pick up the correct answer. Okay, next. Who wants to take the next question? Come on. Quickly come in, yaar, so we'll finish more. Volunteer.
I will, sir. Simran, sir.
Yeah. If you got a patient with multi-station N2 or N3 disease, what are you going to do?
So there's no role for surgery, sir. There's
No, don't say that. Don't say that. Don't say that there is no role for surgery. Don't say that. You have to say, what will you do? Because you could downstage and then offer surgery.
Okay. So we'll
so don't use the word no role for surgery.
Oh, okay, sir.
So what are you going to do?
We'll discuss in a multidisciplinary team meet, and depending on we can either offer the patient concurrent definitive chemoradiotherapy or downstage and then offer surgery after restaging.
Okay, very good. So you have to offer this patient concurrent definitive chemoradiotherapy after multidisciplinary meetings. Okay,
sir.
That is the answer you have to get. Don't use the word no role for surgery.
Sorry, sir.
Yeah, and then you will restage the patient. Okay.
Yes, sir.
You will restage the patient. Now, my question to you, Simran, is when you restage this patient, what are the modalities that you use?
So for restaging, we will be restaging the mediastinum with the EBUS, EUS.
No, that is wrong. What will you start off with?
CT and PET CT, sir.
Thank you. You will repeat the
sir.
CT and PET CT.
Sir.
Okay? That is the answer. That's how you start. You cannot start off with EBUS. This is a common mistake which a lot of people make in the exam. They talk about EBUS before talking about doing a repeat PET scan.
Sir.
All right? So I'm sorry, Simran. I'm pointing
no,
these out to
sir.
you because
no,
these
of
are
course, sir. Very
errors which
point,
people
sir.
make in an exam. Okay? So
sir.
1 minute. Somebody else is trying to log in. Okay, so when I talk about restaging a patient, a patient is always restaged with a CT PET. Okay, all right, carry on. Then what are you going to do?
Sir, after PET, CT PET, and we'll do a EBUS and EUS to stage the mediastinum.
Okay, so 1 minute, wait. In this CT PET, in the restaging CT PET, you found that there was reduced PET activity in the station 4.
Sir, if there's
no PET activity on station 4, will you operate on the patient?
So if there's no PET activity on station 4, then yes, we'll offer the patient surgery with the adjuvant chemotherapy.
No, actually, the answer in this situation should be that I would histologically stage the mediastinum still. Okay.
Right, sir.
So,
sure, sir.
So the answer is you must do EBUS and EUS. Okay, that's mandatory. Okay, so if you have done it before and it was positive, then in the restaging you must do EUS and EBUS again.
Sir.
All right, no matter what is there on the radiology, you must do it again. Okay, and then what will you do if it is negative?
So if it is negative, we'll offer him surgery.
Okay, in a PET negative patient. In a mildly PET positive patient, what are you going to do?
So we'll do EBUS and EUS for tissue procurement, and if that is negative, then we'll do mediastinal.
Well done. Well done. I was listening. I was looking for the word mediastinoscopy. Okay. So if there is PET activity, you will do a mediastinoscopy still.
Yes, sir.
You want to histologically stage the mediastinum before offering surgery. Is this clear?
Yes, sir.
Yes, sir.
Am I making myself clear? These are real life clinical scenarios. You will be asked in the discussion these answers. Okay. Mediastinoscopy is negative. What are you going to offer this patient?
So if mediastinum is negative, then we'll offer the patient surgery, sir.
Excellent. That is the answer. So you will downstage, you will restage, and maybe offer surgery. Okay?
Yes, sir. Yes,
Sir,
sir.
one.
Yeah, 1 minute. Wait, Nikhil. 1 minute. Is this matter clear to everybody? In a
Yes, sir.
multi-station N2, N3 disease, you offer definitive chemoradiotherapy. Once you've done definitive chemoradiotherapy, you will repeat the CT scan and the PET CT. If the mediastinum shows reduced PET activity or no PET activity, you would go ahead and do an EBUS and an EUS. If EBUS and EUS is negative, you will do a mediastinoscopy. If mediastinoscopy is negative, you will offer surgery. Is this clear to everybody? Okay, this is the level of evidence 4C. Yes, Nikhil, come in. You wanted to ask something.
Sir, after restaging and sir, is there any role of repeating MRI brain?
Usually no. The second time, the MRI brain is not part of the workup. Unless the patient has evidence of cerebral metastases like an epileptic fit, seizure, loss of memory, change of personality. All of these will guide you to do an MRI brain. Otherwise, in the second staging, second time around, you don't have to repeat an MRI brain. Is this clear?
So one question, sir.
Yes,
Yeah,
sir.
yeah, go ahead.
So you said only if the PET is negative, sir. So if the PET is positive, then the patient is for medical chemoradio directly, sir?
No, not necessary. If the PET is positive, it could be inflammatory changes.
You still have to prove it.
You still have to prove it.
Right, sir.
So, you know, your PET does not mean you have cancer. So you have to prove what is there in the mediastinum.
Yes, sir.
And so if the mediastinum comes back negative, then you offer surgery. If the mediastinum stays positive, then you go to a second stage chemotherapy, second line of chemotherapy.
Yes, sir.
Is this clear to everybody? This is very important discussions, okay? And these are confusing for people when you are asked these questions in the exam. So am I clear? Am I making myself clear? These are very definitive answers I'm giving you for definitive clinical situations. Okay, who wants to come in next? Some of the international guys should come in, man. Who is there? I can't see who. Who's doing FRCS now, soon? Any of the international guys want to come in and ask? Basam, you want to come in?
Yes, I can do, yes.
Yeah, Basam, tell me, you've done, there is a patient and you have done, he's got a superior sulcus tumor, okay? And you did a PET scan. You did an MRI. Everything is okay, just the tumor is there involving the, it's surrounding the thoracic outlet vessels, okay? But there is no mediastinal involvement and there is no involvement of the intravertebral area, but it is involving the local vascular structures. Okay?
Okay.
Did you understand the scenario?
Yes.
That there is a thoracic outlet tumor with local invasion into the vessels, subclavian artery, subclavian vein, but there is no mediastinal involvement. So the mediastinum is clear. What are you going to do in this patient?
So first, assess the patient fitness for surgery.
Excellent. And then?
And then discussing the MDT.
Excellent. Very good. I like that. And then what are you going to do? What is the treatment for this patient? Give me the treatment. I'm not trying to catch you out. I just want to know what is the treatment for this patient. Are you there, Basam? Hello? Am I audible or not? What's happened? Is my sound gone?
No, no, sir, you're audible.
No, sir.
You're fine, sir.
So what's happened to Basam? Basam, are you there?
Yeah, he's there, sir.
I can't hear you, Basam. I don't know what is happening, but I can't hear you. Hello?
I can go.
Who wants to go?
I can go.
Yeah, yeah.
Hatem,
Say,
sir.
who is I? I don't know. I can't see. Who is I?
It's Hatem.
Hatem. Hatem, come in and tell me, what do you want to do in this patient?
Well, first of all, as Bassem says, you would discuss him with the MTT and provided that he's fit for surgery, so he needs an induction chemorad.
Excellent. I like that. So you're going to do concurrent induction chemoradiotherapy.
Yes, yes.
Okay. And then what are you going to do?
Then restage him again.
Excellent. That is the answer I was looking for. So you restage the guy after the chemoradiotherapy.
Yes.
And it has gone down. What are you going to do?
Well, in this case, if it's gone down, then obviously he will go for surgery.
Excellent. That is the answer. Okay.
And-
It's followed
give it-
by surgery. If it is not gone down,
Connection is lost. Sorry.
So if it's not going down, then again rediscuss to the MDT.
yeah.
And I'm not sure with further chemotherapy.
Yeah, the thing is, if it is operable,
Yeah.
then you can consider him for surgery,
Yeah.
but it will be a higher grade surgery because you might have to resect the subclavian artery and put in an
Yeah.
interposition graft. But
Yeah.
you don't want to give him surgery as the first answer without giving concurrent chemoradiotherapy. Did you
Right,
understand that? So
Yes,
it is
yeah.
still a resectable superior sulcus tumor,
Hmm.
but it's better to give him concurrent chemoradiotherapy, start off with an induction therapy, and
Yeah.
follow it with surgery.
Yeah.
But in between the two, you must restage to know what is happening.
Yeah.
Okay?
Yeah.
Is this clear?
Very clear, yeah.
Very good. Okay. Hatem, tell me again, you finished radiotherapy. How
Mhm.
soon after radiotherapy will you operate?
I will give it period of healing. I think I'm not sure, but I think about 2 to 3 weeks.
What does the guideline say?
Sorry, I'm not
Within 4 weeks.
Yeah, so go ahead. Take a chance, man.
But yeah,
It's
I would
4
say
weeks.
4 weeks. Yeah.
Okay. So the guideline says it is within 4 weeks of radiotherapy.
Yeah.
So 2 to 3 weeks, you're right. Because it is within 4 weeks. It's not at 4 weeks. You understand that?
Yeah.
But know the guideline that surgery should be done within 4 weeks. Don't try to do surgery after 4 weeks. The effect of chemoradiotherapy is lost.
Mm.
Okay? All right.
Yes.
Does it make sense? Everybody
Yes.
understood what I said?
Yeah.
Hello?
Yes.
Yes, sir.
Yes, sir.
Good. I'm happy. These are very complicated scenarios. That's why I'm taking my time and I'm discussing with you guys so that you are able to reproduce in the exam. Okay. What about T3, T4 resectable central tumors? Will you operate on them or will you offer them chemoradiotherapy?
T3, T4, providing they are N0, you can resect.
Good. Very good. So in highly selected cases, the answer I would give is highly selected cases and more importantly, in experienced centers.
Mm.
Okay, that's what the guideline uses the word. And it says that you start off with an induction. You don't resect straight away. You start off with induction and then you follow it up with surgery. Okay?
All right.
Is this clear to everybody or no?
Yes, sir.
So in T3, T4 central tumors, which are potentially resectable, it's better to give concurrent chemoradiotherapy induction and follow it with surgery. That's the guideline. Okay?
Yeah.
Clear or no?
Yes, sir.
What is the time gap between surgery and chemotherapy or radiotherapy?
So,
In this scenario,
4 weeks, sir.
4 weeks. That's the answer. Okay. So again, it is repetitive from the previous situation, but I want to make the point. If you're ever asked this question in the exam, it is mentioned in the guidelines. Surgery should be within 4 weeks after radiotherapy. Okay. Is everybody clear or no?
Yes. Yes.
Something like this. Okay, this is what I meant by that. All right.
So, is this the same situation? Same situation for which concurrent chemoradiation induction and surgery and chemoradio boost has the same result as in the SP2 trial? Is this the same situation, sir?
Yes, it is the same situation, but don't confuse yourself with too many clinical scenarios. Stick to the standard ones that you will encounter in your clinical practice. Everything else that you're mentioning is there. It's part of literature, but not everyday practice. Okay. All right. If you have to do surgery, who wants to come in? Somebody come in. Is Gasam still with us or he's gone? Is Basam upset with me or he's gone?
No, I'm back.
Okay, your voice is crackling a little bit. Okay, Simran come in. No, Nikhil come in. Nikhil.
Yes, sir.
If you have to do surgery in these sort of scenarios, would you do a segmentectomy or would you do a lobectomy?
Sir, I'll do a lobectomy. But if the expertise high volume center is there, I'll.
It's a very simple question, Nikhil. It's not a difficult question. Will you do segmentectomy or will you do lobectomy? Hello? Are you there or not there? I don't know if you're there or not there. I can't see you. Are you there, Nikhil? What's happened here? Is he there? Is he not there? Can you hear me, guys?
I can
Hello?
hear you.
Yes, sir. Yes, sir.
Yes, sir. Bye, well.
So I'm asking you a question in the Vivas. In a patient, would you do segmentectomy or lobectomy? Somebody take it. Atam, take it if you want.
It's lobectomy because it's the according to the size, T3 and T4 is more than this supposed to be for segmentectomy. So it's a lobectomy.
Okay. In my advice to you, in an exam scenario, always give the answer as lobectomy. Okay. That is the gold standard. So you will never be wrong if you say lobectomy. Is that okay? We're not talking about GGOs here. We're talking about a tumor which is seen in the lung. So the safest answer, whenever you feel that you're entering into a controversial area, the safest answer is lobectomy. Segmentectomy in a small GGO is different, but in a nodule which is present in the lung, the safest answer is lobectomy for you guys in the exam. There will be no controversy when you say lobectomy. If the patient is fit, lobectomy is still the gold standard. Is this clear to everybody or not? I'm making a specific point here.
Yes, sir.
Okay, that in the exam, whenever you're asked a question, should you do segmentectomy or lobectomy? See, with Nikhil, I asked him the question and I kept quiet. And he suddenly started going off on a tangent, talking about segmentectomies. You understand? This is how you get misled in the exam. So the answer is very clear-cut. In an exam, always say lobectomy. Okay?
Yes,
the second point I want to make, in an exam, if you're asked, would you do wax lobectomy or open lobectomy?
Sir, open.
Open.
But recommendation says.
Yeah. See, don't go but, yeah. Just don't go but. In an exam, just give one answer and give your justification for that answer, okay? So if you have worked in a center where there is only open lobectomies being done, whatever the recommendation says, you cannot be expected to do a wax lobectomy. And if you're a trainee, you cannot be expected to do a wax lobectomy. Or if you're a recent consultant, you cannot be expected to do a wax lobectomy. So in my exam, if I was ever asked this question, I would say, sir, I would do open thoracotomy and lobectomy. Okay? However, experienced people may do wax lobectomy, yes, but in my hands, I would always do open thoracotomy and lobectomy. You will never be wrong in this scenario. Do you understand the point I'm trying to make? I'm trying to show you safety for an exam. Because the examiner could be an old guy who has never done a wax lobectomy. Even if it's a young guy who does wax lobectomy, he cannot hold it against you for doing an open thoracotomy and lobectomy, because that was the gold standard. You understand the point I'm trying to make? Is everybody clear or not clear?
Yes.
Unless you've done 200 VATS lobectomies in your logbook, then that's different. You can say, I've done 200 VATS lobectomy, I can do a VATS lobectomy. But most young people would not have done that much. They would still have done 10 or 12. They're still in their learning curve. So the best thing to do is say, I would do open thoracotomy and lobectomy with systematic mediastinal nodal dissection. You must mention this, okay? You will sample or do a systematic mediastinal nodal dissection. Now, my next question to you, who wants to take the next question really quickly? Who wants to take the next question? Yeah. Who is that? Give your name.
Sir, Vishwarup, sir.
Vishwarup, my next question to you is, what are you going to do to the mediastinum?
This, which patient, sir? In the same patient, sir?
Yeah, you are operating and you are about to dissect the mediastinum. What are the strategies available to you for doing a mediastinal dissection?
Sir, if we are doing an open thoracotomy and lobectomy, so we will try and take out. I mean, we'll try and do a lymphadenectomy as much as it is possible to do.
Okay, what is the evidence? Is there any evidence to show that systematic mediastinal nodal dissection is better than systematic mediastinal nodal sampling?
No, sir. The evidence is that if adequate tissue is collected, then sampling and this thing will give same result, lymphadenectomy. But
so why do you want to do dissection over sampling?
Because in dissection, sir, the tissue yield will be much better for us, which will be more than the sampling. So we will get better tissue yield. We can take multiple samples, and from there we can do a better histological diagnosis. When sampling,
what is the minimum number of stations that you have to take?
Three, sir. 3.
Okay. So actually, the evidence is that sampling and dissection has no prognostic benefit. Prognostic benefit, okay, has no prognostic benefit. Which study came up with this answer?
Sir, this
Which study specifically looked at this question? Is there anybody who can tell me which study specifically?
Intergroup.
Yeah, okay. What else looked at? Which other very important, big study which looked at the whole thing?
The URTC trials.
With more than 26,000 cases.
The URTC trials, sir?
No, ASCOG Z300.
Yeah, Z0. Yeah, that's the one, yeah. So that's what I mean.
ASCOG Z300 specifically looked at this question as a sub-analysis. Okay, and it specifically said that systematic mediastinal nodal dissection does not have prognostic benefits over systematic mediastinal nodal sampling. However, you must dissect the mediastinum and you must do at least 3 stations. Is this clear to everybody? Hello?
Yes, sir. Yes, sir.
Okay. What is the mortality for a lobectomy that you would quote?
So one question, sir. So one question.
Yeah, okay.
Sorry,
okay. Yeah, I'll come back.
So out of those 3 stations, so then one has to be 7. There was something like that.
Always, one has to be 7. So minimum 3 stations and one always has to be 7. Sorry, I forgot to say that. So the answer should be, you should do at least 3 stations and out of them one has to be 7. Okay? So don't get stuck on dissection, systematic mediastinal nodal dissection. Because somebody will ask you, which study said, where is the benefit of a dissection? What is the problem of a dissection versus sampling?
So lymphoria.
Okay, what else? More important. On the left side.
Recurrent laryngeal injury.
Yeah, so with systematic mediastinal nodal dissection, there is evidence to show that the incidence of recurrent laryngeal nerve injury is more. On the left side, it is the left, and on the right side, station 2, the right recurrent laryngeal can be injured. Okay? So that is why the proponents, you must know a balanced answer between 2. So both are possible, both can be done. There is no problem. If you are used to doing systematic mediastinal nodal dissection, go ahead and do it. But know that the incidence of recurrent laryngeal nerve injury is slightly higher with mediastinal nodal dissection. The incidence of prognostic implication of two are no different. And that was the ASCOG ASCOG Z00300. Okay, that was the study which showed this. All right, what's the Basam? What's the mortality for a lobectomy you quote?
5% for a lobectomy.
Standard.
Well, 5%. Sorry, no, 2 to 3%. Yes, sorry.
Good, thank you. A standard international mortality. If you're doing 5%, then there is a little problem. Okay, then you need to look at your study again. Okay, what are the other surgeries that are acceptable?
Sleeve resection.
Good. What is the mortality for a sleeve resection?
Approximately 5%.
4 to 5%. Okay. What is another operation you can do in these locally advanced? Yeah, pneumonectomy. What is acceptable mortality for a pneumonectomy?
10%.
5 as well.
Actually, the literature says 8%. Okay, so between 5 to 8% is acceptable for pneumonectomy. Okay. Okay. Now my question to you is: if you've downstaged a tumor, okay, if you've downstaged a tumor, who wants to take this question?
Yes, sir.
Yes, sir.
Yeah, okay. Danesh, come in. If you have downstaged a tumor and you still need to do a pneumonectomy, do you think it's a good operation? You understood my question?
Yes, sir. After downstaging,
If you have downstage and you still need a pneumonectomy, do you think it's a good?
It's not a good. It's not a good operation because there are more chances of the bronchopleural fistula formation in the post-op period because of the effect of the radiotherapy and immunocompromised state.
So pneumonectomy should be done. You're right. You're absolutely right. So in a downstage patient, you should try and avoid pneumonectomy. That is what the recommendations say. Okay. And the problem is with the bronchopleural fistulas that can form. How do you prevent a bronchopleural fistula in a pneumonectomy that you needed to do in a post-downstage patient?
Sir, we can buttress that with a pericardial, or with the intercostal muscle flap, or the pleural tenting, or we can use some.
So now let me ask you the question again. What are the materials you can use for buttressing your stump? Give me all possible things that are there in literature.
So the pericardium.
Good.
And then pleural tents, pleura. Then
pleural tent, pleura. Not very common. Talk about the common things first.
Intercostal muscle flaps.
Good. 2. What else?
And
sir, intrathoracic, extrathoracic.
What intrathoracic, extrathoracic?
Sir, intrathoracic is intercostal muscle flap, pleural pericardial patch, while in extrathoracic, the is measured through the second intercostal space.
Yeah, so you have an option of using any of the chest wall muscles if you want to. Okay, so normally you use intercostal muscle flap or you use pericardium. Okay, the other options available to you are serratus anterior can be swung in and put there. You can use piece of a pectoralis muscle if you want, if you're really worried. You can use a phrenic nerve pedicle that's available to you and you can swing it on. Okay.
So even IMA flap, sir?
Yeah, IMA flap usually you try and avoid because you don't want to compromise the chest for the patient, but you can use. You have lots of availabilities options. So this is the whole thing that I just discussed with you. Okay. Look at this slide, take a snapshot of this slide, and this is exactly what I was talking about, okay? So everything that I mentioned is from these guidelines. Does it make sense? Hello?
Yes, sir.
Yes, sir.
Okay, now let's talk about systemic therapy. Okay, a little bit about systemic therapy. You must know this when you are going in for exams. What is the recommended systemic therapy? Chemotherapy. I don't want details. I just want to know what is the recommended one.
Platinum-based chemotherapy with zinc alkaloid.
Okay, always in the exam, the answer to give is platinum-based chemotherapy. Okay, stage level of evidence 1, recommendation A. Is this clear to everybody? I don't care if you don't know the name of the drug. It doesn't matter. Just say platinum-based therapy. Is this clear?
Yes, sir.
Okay, so just use the word platinum-based therapy. That is what is recommended. 1A. Okay, so very, very high level of evidence for that. Okay, all right. And nowadays they are looking at PDL1 checkpoint inhibitors. Okay, but they are all being evaluated. That they have not yet been made into the guidelines. Okay, so everybody clear about this? I'm giving you easy answers to give in the exam. Okay. All right, somebody else come in. Simran, unresectable tumor. What treatment do you want to give?
So first we'll discuss the case in the multidisciplinary team meeting, and we'll offer the patient.
1 minute. I really like it, Simran. After our last case presentation, I really like it that you have understood that you must say MDT all the time. Because I stopped you on this one. Okay, I held you back. So this is why education is important. I have to ask you a question. Because when I point out the obvious, you are able to reproduce it next time. So well done,
sir, I'm telling you, sir, on a personal level, sir, you have no idea how helpful these classes are, sir. Because sir, we don't think thoracic, no, sir. We don't think thoracic.
Of course, of course. Well done. Carry on. Tell me, what are you going to do?
So we'll offer the patient concurrent chemoradiotherapy.
Excellent. And what's the level of evidence for that?
So high level, 1A, sir.
Okay, good. Very good. And if concurrent CRT is not possible, or the patient is not fit?
So it's called sequential therapy, sequential radiotherapy, chemoradiotherapy.
Sequential. So sequential, what will you give first, radiotherapy or chemotherapy?
Chemotherapy.
Yeah, so sequential chemotherapy followed by definitive radiotherapy. Okay. Is there any role for prophylactic total brain irradiation?
No, sir. There's no role for no, sir.
So there is no role for
There is role in the small cell.
Yeah, but this is non-small cell. Look at the heading.
Oh, yeah. Oh, sorry.
Look at the heading. It's non-small cell lung cancer. We are not talking about small cell. So is there any role for prophylactic cranial irradiation? This is actually mentioned in the guidelines. It's a 2A level of evidence that there is no role for prophylactic cranial irradiation. Okay. So what I want you to notice is the first line and the third line, and look at the level of recommendation. You must remember this. So when I answer in the exam, my answer would be like this. Sir, according to the guidelines, there is 1A level of recommendation that sequential chemotherapy should be followed by definitive radiotherapy in a patient in whom concurrent radiotherapy is not possible. Did you understand how I said this? Or if it was the first scenario, I would say, according to the ESMO guidelines, there is 1A level of recommendation that this patient should get concurrent chemoradiotherapy. Did you get the line which I just said? So the moment a candidate tells me like this, that according to ESMO guidelines, one, I know he has read the ESMO guidelines. When he says, there is 1A level of evidence, it tells me that he understands level of evidence and stages of recommendations. And then the third one is the actual answer, okay? So in the exam, don't come up with just concurrent chemoradiotherapy and keep quiet. You're absolutely right. But why not use the opportunity to tell the examiner that you have read guidelines? Do you understand that? So when you answer in an exam, I want you to say, whenever I ask you, here is an unresectable locally advanced non-small cell lung cancer, your answer should be, sir, according to the ESMO guidelines, there is 1A level of evidence suggesting that this patient should get concurrent chemoradiotherapy. I want you to practice this. Keep practicing this sentence. Just like Simran said, I would discuss this patient in a multidisciplinary team meeting. Unless and until you say this again and again, it will never come instantaneously in an exam, in a Viva. So you have to keep saying this. I would discuss this patient in a multidisciplinary team meeting. According to the ESMO guidelines, there is 1A level of evidence that this patient who is an unresectable non-small cell lung cancer should get concurrent chemoradiotherapy. If he is not fit for chemoradiotherapy, or if concurrent chemoradiotherapy is not possible, then there is 1A level of evidence that this patient should get sequential chemotherapy followed by definitive radiotherapy. Each word is important, okay? Definitive radiotherapy. You have to use the word definitive, okay? So quite important. Did you understand what I just said, or am I just making it confusing?
No, sir.
No, sir. No, sir.
No, sir.
Good. All right. Let's go to the next one. Next clinical scenario, okay? What will you give for this patient? Simran, you can take this again. Or Bassam can take it. Wait, Simran, wait. Let our international group do some participation. Okay.
Yes.
Bassam, are you with us?
I am, yes.
Yeah, Bassam, what will you give him? Chemotherapy.
Well, I'll give platinum-based chemotherapy. I'll give cisplatin.
Excellent. I like that. That is the answer. Don't give names of the drugs. Just say, I would give 2 to 4 cycles of cisplatinum-based chemotherapy. That's a very good answer. Well done. Bassam, what's the cumulative dose of cisplatinum that you have to give?
No, I don't know.
Okay. Somebody else wants to just take it? I'm making these points because this is all you need to know about chemotherapy.
300 mg.
Sorry?
Sir, 300 mg per meter square.
Excellent. 300 mg per meter square is the cumulative dose that you can give. Okay? It's very easy. I'm not making it confusing. I'm giving you specific answers to give in the exam. So you give 2 to 4 cycles of cisplatinum-based chemotherapy up to a cumulative dose of 300 milligrams per meter square. That is the answer you have to come out with. Okay, and again, this is from the guidelines, okay? That is the guideline. Yeah? Okay, all right. Let's go to the next radiotherapy. How would you use radiotherapy? In what context would you use radiotherapy in these patients? Would you give isolated radiotherapy or would you give a combination radiotherapy? Who was there with us before who answered? Hatam was there, no? Hatam,
Yes.
are you still with us?
Yes, yeah, I'm here.
Yeah, Hatam, if you had to give radiotherapy, would you give isolated radiotherapy?
I'm not sure really. I don't think that we give isolated radiotherapy. I think we.
Okay, so how will you use radiotherapy in an unresectable non-small cell lung cancer? What is the recommendations? Always give it as a concurrent chemoradiotherapy.
Concurrent, yeah.
So it was not a difficult question. I was asking you.
Yeah.
Radiotherapy will always be used, but only when it is concurrent. Okay.
Mm.
So along with chemotherapy, you would give. Just radiotherapy itself does not work. Okay. Okay, Hatam, what is the dose of radiotherapy? Maximum dose of radiotherapy you can give?
So again, I haven't revised it. I'm really sorry.
It's okay. Somebody else come in. Who
Sir,
wants to take this? Vishwarup,
Sir,
what is
Vishwarup.
the maximum dose of radiotherapy?
So 60 to 66 grain, 30 to 33 daily fraction in a time interval not exceeding 7 weeks.
Excellent. That is the answer. Okay. So let me go through this one by one. Okay. 60 to 66 gray radiotherapy. This is the answer you have to give in an exam when you're asked about radiotherapy, when it is concurrent chemotherapy. So 60 to 66 grays, 30 to 33 daily fractions, and the duration should not exceed more than 7 weeks. Is it easy?
Yeah, very clear.
Okay.
Yeah.
Yeah, very clear. No, there is no confusion in these things.
Very clear.
I'm giving you the
Yes, sir.
points as they are. Okay. All right. Good. All right. So this is all from that thing. Can you see this? Here it is for concurrent radiotherapy. 60 to 66 gray in 30 to 33 daily fractions is recommended, and the maximum time allocation should not exceed 7 weeks. So the problem is when you read the paper, These things don't catch your eye. Okay, but when you see my slide, it gets highlighted. You see, that's the point. That's the reason why I'm teaching you. I'm teaching you just to highlight the important things. It's not that I'm teaching you anything new. Everybody knows this. But only when I ask you, like Basam uses, Hatham must be doing this every day, sending a patient for radiotherapy. But it has not stuck in his mind, that the maximum dose is 60 to 66. So I'm trying to highlight it in your mind. Okay, that's all I'm trying to do. So it is there in the guidelines, but this will not stick in your memory until and unless somebody questions you. So now I've questioned you for the rest of his life. Hatham will know it is 60 to 66.
Definitely now.
Grace. Okay. So that's the idea of doing this education. It's not meant to put you on the spot or humiliate you or anything like that. It is only meant to make sure that you remember the next time I ask you this question. Okay? Everybody happy with that?
Yeah.
Yes, sir. Yes.
Okay, good. Good. I'm happy. Now this is okay. This is actually the treatment protocols. You must take a screenshot of this and please keep this with you. And then any patient that you're asked will be within the context of this guideline. Anything that you're asked, you will be asked within the context of this guideline. Take a screenshot and keep it with you, or go to the ESMO paper. It's freely available, the ESMO guidelines. Okay, and you will be able to answer this. These are 2 or 3 charters which are all there, very clearly defining which patient goes for what. Okay, all right. Any role for personalized medicine in clinical practice? Simran?
No, sir. No role for targeted outside clinical trials, sir.
So if you have to give targeted therapy, the patient must be enrolled in a clinical trial. That is the answer you have to say. Okay? That I'm very happy to give targeted therapy, but he should be in a clinical trial. That is very important. Any role for immunotherapy in routine clinical practice?
So not according to the guidelines, sir.
So what would you do? Would you give immunotherapy or no?
Depending on the immune
answer I'm looking for. Sorry?
Depending on the whether he has VGF receptor positive or negative.
The answer again is just it's staring at you in there. I would give immunotherapy in a clinical.
In the clinical trials.
Full stop. Don't even go there or whatever. I'm not interested in details. I'm looking for the fact that are you a safe surgeon or not a safe surgeon? Okay, or are you a safe oncologist or not a safe oncologist? Okay. So always whenever you're asked and answer a question which is outside your remit, the safe answer is to give, I would give it in the context of a clinical trial. That's the point I'm trying to make here. It's not about immunotherapy, it's not about targeted therapy. You must say that yes, sir, it can be given, provided it is within a clinical trial. Okay? All right, well done. It's there. It's in the guidelines, okay? All right. Is everybody happy or not happy? So far, so good.
Yes.
Is it clear? These are very difficult clinical scenarios, and until and unless somebody explains to you each and every situation, it will never register in your brain. Okay, somebody come in. Soumya, you want to come in? Soumya, are you with me? No. Okay, somebody else, whoever is with me.
Yes, sir.
Nikhil, come in. Nikhil, how will you follow up a patient?
I'll follow up this patient every 3 months with history and physical examination, chest X-ray, and a CT scan.
So, for how long will you follow up the patient?
So initially for 3 months, for 2 years, and then every 6 months for 3 years. For next 3 years, that is total 5 years.
Okay. So actually, the guideline ESMO says 24 months. Okay. So ESMO says that CECT should be done 12 and 24 months. Okay. If it is a salvage therapy, then it's for 3 years. And PET scan is not a routine follow-up modality. Okay. So if you're asked whether, how will you follow up this patient? You follow up with CT scans, not with chest X-ray and not with PET scans. Okay. You must know this answer. The follow-up is always with CT scan, and only if needed, then we do a PET scan. If we find CT evidence of recurrence, then we do a PET scan. The one important thing is if you ever have recurrence, what should you do? If there's any suggestion of recurrence, how do you confirm it? Can you treat it with chemotherapy if there is a PET evidence of recurrence?
Tissue sampling, sir.
Tissue sampling is mandatory, okay? So no treatment should be given without biopsy. That is very, very, very important, okay? What are the other therapies that you have to give when you are following up a patient? Besides clinical therapy, what are the other therapies you must mention in your discussion with the patient, with the examiner?
Chemotherapy.
Stop smoking.
No. We have done clinical treatment is done. What else can you do?
So stop smoking.
Behavioral and pharmacotherapy for smoking.
Lifestyle
Smoking
modification.
cessation is mandatory. So in the exam, don't forget to talk about smoking cessation. Okay, it does give rise to superior outcomes. And don't forget about behavior therapy and pharmacotherapy. Okay, this is there in the guidelines. It is all part of the guidelines. It's not something that we've made up. Look at that. It's all there in the guidelines. Okay, so that's that we have to do in lung cancer. Is everybody happy? Anybody's got any questions?
Yes, sir.
Okay, go ahead. Ask me the question.
So the guidelines is follow for 2 years and 3 years. Sir, but when we assess the prognosis, it's a 5-year survival or 10-year survival.
That's the minimum requirement that you have to do. Minimum follow-up of 2 years.
Okay.
Yeah. Okay. Now, all right. We finished lung cancer locally advanced. The 5. Is everybody clear about every single scenario you can face? Anybody's got any questions? Hello. Yes, sir, or no, sir? Something you have to say.
Yeah. Can I ask one question, please?
Yeah. Who is that?
Yeah.
Just identify and then
It's
say.
Hatem.
Hatem, tell me.
Yeah, just regarding the N3, because when I joined, it was just when I just joined when you talked about it. N3 is still, I thought N3 you would not be for surgery, but you still need to downstage it if it's still possible to be operated on.
Yeah.
I just want to make sure about this, if you don't mind.
Yeah. If N3 is present, usually it's not for surgery.
Yeah.
But if you restage and you have downstaged it, and the mediastinum comes back as histologically negative, and he's a young fit guy, then the guideline gives you the ability to operate on the patient.
So in this case, we cannot refuse surgery at all. In this case, isn't it? We never can say.
Yeah, if it's a young fit guy and he's been downstaged and all of it, all the mediastinum has come back negative, then you should consider him for surgery.
Thank you very much.
Okay. But traditionally in an N3, don't talk about surgery. Okay. Yeah. Traditionally, N3 is usually chemotherapy.
Yeah.
But he's come back, he's responded beautifully. He's had his whatever first stage, second cycle chemotherapy, and there is no mediastinum nodes. Should you actually say no, I will not operate on him if there is, because there was one left-sided station 4. Actually, the guideline says if he's a fit guy and everything is gone, then why not offer him surgery as a therapy? Okay.
Thank you very much.
All right. Now we're going to come back to MCQs and not MCQs. We're going to come back to Vivas, and some of these questions may come in the MCQ. Okay. So are you still with me?
Yes.
What is the time? 10:30. Okay. Now these are easy questions. I want quick answers. Okay. Who wants to take this question?
Yes, sir.
Yeah. Who said yes, sir?
Nikhil.
Nikhil. Okay. Nikhil, tell me 5 stages of primary survey. Nikhil, have you done a base BLS course?
Yes, sir.
Excellent. Very good. So now tell me 5 steps of primary survey in a BLS.
So primary and secondary. Primary airway, breathing, circulation.
This is not ATLS, okay? Nikhil, this is not ATLS. What are the 5 steps of BLS? Primary survey in a basic life support. You walked into a room, you found a patient collapsed. What are you going to do?
Sir, assess the airway and assess the airway, took a pulse, blood pressure.
And what you did not see was there was a live wire there, which you just got shocked. And you died as well.
Scene service, sir. Scene safety.
So what are the 5 steps of BLS? It's very clear cut. BLS is very standard, very clearly mentioned. What are the 5 steps of BLS? See, very basic. This is the basic which you must know. So like Simran asked yesterday, will you be upset? Yes, I'll be upset if you don't know the 5 steps of BLS. I don't care if you don't know what happens in N3 disease, but if you don't know the 5 steps of BLS, that will really upset me in an exam. Come on, guys. It's Dr. ABC. It's Dr. ABC. DRABC. Tell me, Biswarup, 5 steps of BLS.
Sir, we will ensure the scene safety, the scene is safe. Then we will check for the responsiveness. We will shout and try to talk to the patient.
Excellent,
The patient is not breathing.
That's good. So first is danger.
Yeah.
Wait. Let me go slowly because I'm trying to make a point to everybody. So first is danger. D is danger. Make sure that the scene is safe for you to go in.
Yes.
And the next you said correctly is you look for the response of the patient.
Patient.
So you have to shout out to the patient, hello sir, are you okay? Hello sir, are you okay? Are you alive? You know, things like that. Not alive, but you have to say, hello sir, are you okay?
Yeah.
Then what do you do?
Which we cannot check his breathing for more than maximum for 10 seconds. If he is not breathing, we will immediately
check for airway. Check for airway. What's the next thing you do? Check for airway. Then what's the next thing?
If he is not breathing or he is breathing insufficiently.
So check for breathing. And what's the third thing you do?
And then we call for an emergency medical EMS or in.
No, before this, what is the next step? There is one step missing. There is the 5th step.
Circulation.
Circulation. Check for circulation. Yeah. I'm very sorry, but you have to know these answers in the sequence that they have been designed. Okay. You cannot, everything you're saying is right, Biswarup. There's nothing wrong with what you're saying. But you have to tell me in the steps that it is designed. The reason for this is so that everybody has a universal response to basic life support. That is why these steps are put. Okay. ATLS is A, B, C, D, E. It's a universal response so that everybody does the same thing when they see a patient. That is why BLS, you must do it as Dr. ABC, D-R-A-B-C. First is look for danger, look for the response of the patient, look for airway, look for breathing, and look for circulation. Is it clear? I'm sorry, it's a very basic question, but I do want you to be able to answer the basic question. Okay, now this slide, just look carefully at the next slide, okay? This is what you have to do. Is it clear? Read the slide now. Okay, so always make sure the area is safe. Check for the patient's response. Shout for help so that somebody is there to help you. If the airway is not clear, tilt the head back. Use one hand on the forefinger, 2 fingers under the chin. Check for breathing. Look for listen. Look and listen. That is the whole thing. So look for the chest movement, listen for the chest movement, and then check if the circulation is normal. If there is no breathing, there is another step. Okay, I'll talk about that in a minute. If breathing is not there, then you have to do something. But if breathing is normal, then you look for circulation. Is it clear? Very, 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 very basic thing. Okay, now my next scenario is at this point, Simran, come in. At this point, the breathing was not normal. What are you going to do?
Sir, you give
Sorry, 1 minute. The breathing is normal. Tell me, the breathing is normal and there is a pulse. What are you going to do?
So if the breathing is normal and there is pulse, so then you attach a AED.
Arey Baba, your breathing is normal, pulse is there. Why do you want to put an AED?
We'll set rescue breathing, sir.
Breathing is normal. Why do you want to start rescue breathing? What is the thing that will kill the patient here?
Aspiration. Turn him on the side.
So what are you going to do?
Turn him on the side.
Thank you. That is the answer, okay? If the breathing is normal and the circulation is there, but the casualty is unresponsive, you turn him on the side. Put him in a recovery position. See, these are very basic things. I know you know the answer. But if you're not able to reproduce, then I will struggle with that. Okay? All right. Now, the next scenario is that the casualty is unresponsive and the breathing is not normal. What are you going to do? Who wants to take it? Viswarup, take it.
Still then we will check for pulse. If the pulse is present, we will start rescue breathing. If the pulse is not present, we will ask for a defibrillator.
Defibrillator. Oh, excellent.
No, we will see his breathing. If he's breathing and is not breathing well, then we'll still see for pulse. If the pulse is there, we will start rescue breathing. If the pulse is not there, then we will attach him to an AED.
If the pulse is not there, what is the first step you will do?
CPR, we'll start CPR.
Yeah, so that is the bloody answer. I'm sorry, I'm getting agitated. But see, this is the problem. You guys talk about defibrillator straight away. Or you talk about AED. Who's going to do CPR? See, if you don't follow these pathways, now you miss things. So it is very clearly written. You start CPR. I want the word CPR. Start CPR. Okay? I'm sorry, I'm getting but if you talk about defibrillator before you talk about CPR, I'm not impressed in an exam, you know, so just be careful about it. Yeah? Is this clear?
Yes, sir. Yes, sir. Yes, sir.
Okay, so this is what you do, okay? Whatever you want to do. CPR, how many times do you do it? What is the rate of CPR?
More than 120 per minute.
Yeah,
So
okay,
100 per
that's
minute.
the rate of CPR. Yeah. Okay, 100 to 120 per minute. What is the current guidelines of COVID in a basic life support? What are you supposed to do if you find a patient has got COVID, or you suspect a COVID, or you don't know if the patient has COVID or not?
Sir, we will do, if we are suspecting the patient might be COVID, we do not know the COVID status of the patient. In spite of instead of giving rescue breathing, we will give him a bag and mask breathing.
No, what is the guidelines say?
So is it first call for help, then cover your nose and mouth, cover the patient's nose and mouth, and give only CPR. No breaths, only CPR.
Yes, absolutely right. So the guidelines for COVID says that you cover the patient's face and do not attempt to resuscitate the breathing. You call for help, cover the patient's thing, and only do cardiac massage. Okay, that is what the guidelines say. All right. I'm sorry, I'm getting you at a very basic level, but I just thought it would be interesting to see if you guys know the guidelines.
It is fine, sir. It is fine. It is fine. You should know, sir.
Yeah, okay, all right. Now comes the more difficult parts. Come on, guys. Who wants to take this? I want the UK trainees to take this if they know it. Who is with me? Who is there? Anybody from UK who is working in the UK? Nobody wants to take it? Hatam, are you working in the UK?
Yeah, yes, I am. Yeah.
Ah, come on. Don't stay quiet. What is clinical governance?
Clinical government is a body that, well, there's a classical one, but it's a framework where they look at the providing good service to the patient, sorry, it's not on my head, but I try to remember providing a good space area, providing a safety for a patient, and sorry, just I couldn't get it.
Yeah, And I actually in an interview when
I
you
know
come
what it is,
for
but I
a
couldn't put it
registrar
in
interview,
words.
I will
Yeah.
always ask you, Hatan, this question. Okay, what is clinical governance? And you should be able to answer it off the top
I
of
know.
your head.
Yeah.
So the definition of clinical audit and the definition of clinical governance are very
The 7
important.
pillars. Yeah.
If you come into my job and I ask you definition of clinical governance, you should be able to rattle it off the top of your head. Is there anybody who knows the definition of clinical governance?
Sir, I have read it last night only, so I can probably tell after
Go ahead,
class.
go ahead. If you've read it last night, please tell me what is the definition.
It is a system through which the NHS hospital are accountable for improving the quality of service and the patient safety and high standard of care by creating an environment of positive clinical practice, clinical excellence.
Okay. So my suggestion to everybody, all of you who are ever thinking of working in the UK, or if you're thinking of ever of doing the FRCS exam, is this is a very simple question, but unfortunately, almost everybody struggles with this. So my suggestion to everybody is that you must know this by heart, which means that if I wake you up in the middle of the night, you should just come out with it. It's a framework through which health organizations are accountable for continuously improving quality of their services and safeguarding high standards of care by creating an environment in which clinical excellence will flourish. Okay, there are lots of things which you learn in life. This one, please learn it and keep it in your mind, and every so often, particularly before a Viva, or more importantly, before an interview, please revise this so that you do not waste any time in the exam on this stupid question. Okay, it's such a simple, straightforward question. You must know it. Okay, now my next question, Atam, you can continue because you work in the NHS. What are the 7 pillars of clinical governance? Just name them, that's all. I want you to name them. And this will come in the MCQ, I promise you this.
Yeah. There's very important 7 pillars in the UK government, which is one of them is including audit, also risk management, and patient and public involvement openness. There's the IT and information, and the management of the staff, and the last one, which research.
Okay, so the first one is service users, which is carer and public involvement. That's one of the pillars. The second pillar is risk management. The third pillar is clinical audit. The fourth pillar is staffing and staff management. The fifth pillar is education and training. The sixth pillar is clinical effectiveness. You forgot to mention clinical effectiveness. And the 7th pillar, which you said is IT, is called as clinical information. Okay? Please know this, and please know this graph. Take a screenshot if you need to, but just know this graph. It is important. Know this chart, not graph, know this chart. Okay? So systems and processes, clinical audit, clinical effectiveness, practice and standards, which is audit, education and teaching, and risk management. Okay, so I'll go back on my slide and show you this slide. Just these are the words you have to use in the exam or wherever I ask you this. Okay, all right. Is it clear?
Yes.
I won't ask this difficult. Okay, somebody come in and tell me how do you calculate a sample size? What are the 5 factors in calculating sample size? Anybody can take it. Nikhil, do you know the 5 factors used to calculate sample size? You've done a thesis.
So the previous studies.
No, how do you calculate? You have decided that I want to have 200 patients in my study. How did you come to the number 200? What did you look at? This is my very beautiful Viva question.
I was going to forget. Can't
okay, okay, Simran, come in. Simran, what are the 5 points I take into consideration when I am calculating a sample size?
No idea, sir. That's I have
Okay,
to read
somebody
up
else
on.
come in. Vishwarup, come
Yes,
in.
sir. Can I come, sir?
Okay,
Sir,
yes.
I will try, sir.
No, wait.
Dinesh.
Danesh has said yes. Yeah. 5 factors you
Sir,
take in.
the prevalence, and then the power of the study. We want the confidence interval, then power and prevalence. And
5 factors. So first is level of significance. Do you know what is level of significance?
yes,
The
sir, level of significance.
95% and 98%
Confidence
confidence
interval.
interval. So
Yes.
first that you do is you decide whether I'm willing to accept 95% confidence interval or whether I'm willing to accept 98% confidence interval or whether I want 99% confidence interval. What does it mean if you go higher on this? What does it mean?
Yeah. Sir,
If
if we
you
want more,
accept 80% versus you accept 95%, what is the difference between the two?
sir, for the 95% confidence interval, we will need more sample size.
Good, excellent. So the higher the level of significance, the higher is the sample size. Well done, Ganesh. What was the next point? You just said that. You said power of the study.
That power
Okay.
of the study.
Fine. What else do you want to look into before
The
sample size calculation?
prevalence of any disease or factor, sir. Prevalence.
Okay,
Previous
good.
prevalence.
What else? Yeah, good. You're right.
Precision
You're
that I
going
want
right.
in the study.
There are 5 things I want to know. What else?
The precision of the study, the precision the level of precision that I want. How many times can I?
Effect size. Okay, you have to know what is the effect size that you're willing to accept in the population. The underlying prevalence rate, as you rightly said, and what else? What's the last point? Something. There's a bell. There's a bell which goes. A bell-shaped curve. What is it?
The standard deviation.
Yeah, the standard deviation within the population of the disease. Okay. Now again, this is something that you've read hundreds of times, but when I ask you in a Viva, you will not be able to reproduce it until and unless you've seen this slide. Okay. So please be careful about this. This is MCQ, by the way. All right, this is definitely in the MCQ. So the question will come that I am doing a study, I'm designing a study, I'm calculating the sample size of this study. All the following factors are important except, and I'll throw in something there which will be except. So you must know these 5 points. Okay? Remember this MCQ, okay? I'm trying to give you a hint here. Okay. All right. Next is, let me ask you another question. What is type 1 error? What is type 1 and type 2 error?
Sir, the type 1 error is when we reject the null, when the hypothesis was true, but we ignore it. And when the null hypothesis was true, but we ignore it, it's called alpha error or type 1 error.
So what is type 1 and type 2? Tell me both. I want to know.
It means when the significance was there, but we denied it.
Which one is type 1? Which one is type 2?
So type 1 is when there is significance, but we denied it's type 1 error. And type 2 error is...
Are you sure?
Yes, sir.
So type 2 error is when a difference exists between the group, but you fail to detect it, okay? Which is also called as false negative.
False negative.
Yeah, that's a type 2 error. And a type 1 error is you detect a difference when no difference actually exists in the study. It's called as false positive. Hello, everybody with me or no?
Yes, sir.
Yes.
See, this is how an exam goes. It moves very quickly from one, you were just talking about N3 disease. Suddenly I've asked you about basic life support. Suddenly I asked you about clinical governance. Suddenly I asked you about statistics. This is how the Viva goes. We keep moving from topic to topic to topic. Okay. And I'm just trying to train you how to switch gears. within your brain. I'm sorry, but this is the practice you'll have to do. You'll have to get somebody to sit opposite you and ask you these questions so that you can quickly switch gear from an N3 disease to some completely different. Okay? Is it making sense or is it upsetting people? Are you getting more and more stressed? I can see
No, sir. Please.
a lot of people are logging off, which is a sign that we are not doing well. Okay, so I think we will call it a day now. It's almost 11 o'clock.
Sir,
We've done this for 2 hours.
Sir,
yeah, sorry.
Sir, but still 95% people are there. So we are 2 standard deviations. Sir.
Oh, all right, okay, acceptable. Acceptable. See, the point is sometimes when I do this study, this sort of education, it is very depressing for the person across me. Many a times it is very encouraging, but sometimes it puts you down in a big way because you suddenly realize that shit, I don't know. Like basic life support is an everyday thing, and then suddenly I have asked you a question and you struggle, so it upsets you. So that's why my aim has always been education, not to put somebody down. Okay, but I think we should do more sessions like these, so that you know exactly, how quickly it moves from topic to topic, and it's the breadth of knowledge that you need, not the depth of knowledge. In this exam, it's all about breadth of knowledge. I don't need you to